Good afternoon, everybody. We are going to start our new session, and we will discuss in this session supporting care and toxicity management. We have 4 distinguished speakers in this session. First speaker, Dr. Kontouli from Greece. She talks about advances in pain management. Please, Dr. Kontouli.
Okay, now everyone can hear me well, thank you. Good afternoon, everyone, and I would like to thank the organizing committee for this invitation. I am not an oncologist, I am not a surgeon, and I think I am the only pain physician in this room these 3 days. I'm here to address an issue which still is a problem with your patients, and when you find it very difficult, then you call us. So the experience of pain in cancer is widely accepted as a major threat in your patient's quality of life, and the relief is a priority of all physicians who actually manage this patient. Pain is associated with both the disease as well as the treatment, and I will be very happy to hear in the future that immunotherapy, for example, does not cause any pain or any problems like chemotherapy. It is really important that we actually manage this pain from the beginning because it's going to be very late afterwards. And as you can see here, 72% of people who have been diagnosed with cancer on the day of diagnosis, they do have pain. And usually it's the symptom that brings these patients to the doctor. And the scores are very high over the countries in Europe, and this is prostate cancer. It should be one of the cancers that does not cause pain as much as other cancers. And you can see that although we are extending patients' lives, the pain is still there, and patients live with pain most of the years before they die. So we have patients that they live with pain up to 5 or 10 years, and 90% of prostate cancer patients, they experience pain in the last year before they die. Who is taking care of that? I know you decide about the treatments. I know you decide about which chemo or other supportive treatments the patient should have. It's mostly the oncologist. And the pain physicians is only 3%. It's the GPs, the oncologists, sometimes the surgeons. So we really need to work together to improve that because it seems that we're not doing it well. This is a questionnaire that the patients answered, and the question was, does your doctor ask you about pain every time he sees you? And the results are quite disappointing. Few consultations with the oncologist, and the oncologist did not ask about their pain or did not care about the pain. And 50% of the patients feel that the oncologist does not care about their pain. That's why they don't ask them. And why do we really need to address this issue? Because the patient who is in pain will live less. Even if you treat them with the best treatment that you already have or newest treatments that probably will come in the future, your patient in pain does not have a quality of life. I want to make sure here we understand performance status is completely different from quality of life. I can perform, but my quality might be very bad. I can be in pain, I can have anxiety, I would not be sleeping well, but I'm strong, I'm 40 years old, I have breast cancer and I can perform, but my quality of life is not as good. So we really need to know exactly what causes this pain in order to treat it well. And most of the times it's the oncologist who is treating this pain. The lesion, the tumor, is it post-surgery, post-mastectomy, post-thoracotomy pain? Is it post-chemo, usually neuropathic? The patient is describing pins and needles in their hands and the feet, and it's worse at night, and they can't sleep. Post-radiotherapy as well. And bone metastasis is when most of the patients come to the doctor and they say that it's really painful. Ascites and other abdominal problems as a complication of the tumor can cause pain in the abdomen, very, very difficult to treat, as you well know. And we need to know exactly, is it somatic, is it the tissues, or is it neuropathic, the nervous system? Most of the times in oncology patients, it's mixed. So we really need to know what to give to these patients. Okay, we start with most simple drugs, and then we can go into interventional therapies for pain, which they developed day by day very much. NCCN do have guidelines for pain, and it would be very good to follow them. They start with very simple analgesics, and as we go up, we add more and more strong opioids. We start with weak opioids in the beginning, and then we go up to morphine or fentanyl. Fentanyl is 10 times stronger than morphine. So what's new? We do have a new fentanyl, Fentora, which is fast but short-acting for breakthrough pain. Always remember to treat background pain first. If background pain is well controlled, breakthrough pain will be less frequent and less strong. And also we have tapentadol. We all know tramadol. When we start giving weak opioids to our patients, we start with tramadol. Tramadol is very, very safe. It's a weak opioid, doesn't do any respiratory problems. Tapentadol is new. It's been announced the last 24 months. It's a weak opioid like tramadol. It can be very well combined with paracetamol, non-steroidals, which you don't really use that much. But it also has a noradrenaline reuptake inhibitor effect, which makes it more effective to neuropathic pain. Most of your patients are on fentanyl patches, and you start fentanyl patches. It's very easy to use from the patient. Every 3 days they change it. They do have adverse effects, which we need to know and treat from day one, such as constipation. So if our patient is cachectic, what you usually do, you decrease the dose. Fentanyl patches, you really need to increase the dose on cachectic patients. Fentanyl patches do absorb from the subcutaneous tissue. If your patient is skinny, they don't have any fat, no matter how much fentanyl you will give them transdermally, it will not get absorbed and the patient will be in pain. And also we have to be very careful with opioids. Over the Atlantic, in the States, they use a lot of opioids, and they do have quite a few deaths. It's been increased 540% in the last 3 years. This includes non-cancer pain patients, but we really need to think about it. And then we come to morphine. Morphine, it's very strong. Unfortunately, in Greece, we do not have oromorph, which is liquid morphine the patient can take at home. But as you can see here, worldwide, morphine is very much used, and this is milligrams per capita, not per patient. This is how many milligrams we use per person living in each country. And as you can see, in Northern Europe, Northern America, and Australia, they use most morphine in the world. In Greece, we can do morphine subcutaneously. Again, this cannot be done in cachectic patients. If the patient is too skinny, this will not get absorbed. A good solution for that is intrathecal. So we implant a pump. We do 20 to 25 patients per year where everything fails. Then we can do a pump in their body. It's implantable. We use 1/100th of the dose that we used when we were giving the morphine peros, and it is totally controllable from the doctor, and the patient cannot overdose it himself or herself. Nowadays, the pain physicians are doing a lot of interventional treatments, such as neurolysis. We try to kill the nerves that are causing the pain. Unfortunately, it's not possible in every part of our body. Maybe in the future we will be able to do that too. and we can do it caudally, lumbar, thoracic, some peripheral nerves that have been damaged from the tumors, as well as stellate ganglion on the neck for arm pain. We used to use alcohol, now we use phenol. That's also something new. It's more stable and it doesn't have as many complications as alcohol. Bone metastasis pain. Well, radiotherapy is the golden standard here. I think these patients should go to the radiotherapists first before they come to the pain clinicians. If radiotherapy fails, then we can implant these patients with an intrathecal morphine pump. Never forget adjuvant therapy. Together with our pain analgesic drugs, we need to combine steroids, antiepileptics, which are great in neuropathic pain. And as I said before, cancer pain is mixed, somatic and neuropathic. Antidepressants such as amitriptyline has a very good role in neuropathic pain as well. And always remember to ask our patients, are you in pain? And do you have constipation? Are you feeling nausea? Do you vomit? Do you sleep well? Etc. So medical cannabis, I'm totally against, but still, they're going to be using it in Europe more and more in the next few years. It's free in Canada, and it has a very good effect on neuropathic pain, and people with cancer can use that. In Greece, it's still illegal. So as a conclusion, I want to say that we really need to work together. When you find it difficult, just refer the patient as soon as possible to the pain clinician. We're here to help and work with you. And also remember that although you stop your therapies and you go to palliative care, your role with the patient is until they die. And 87% of patients with cancer die in the hospital, usually in intensive care unit or HTU. And we need to have a protocol, like an end-of-life protocol, where the patient number one priority is pain management, fluid, oxygen, and then it comes to every doctor's decision which drugs to give or not to give. But number one is pain management. They are actually introducing, and this probably will be in the next guidelines on NCCN, that there will going to be no limit on morphine at the end-of-stage life protocol. Thank you.
Thank you, Dr. Kontouli, for clear presentation. Is there any question or comment? Yes, please.
Congratulations for your presentation. Great, excellent. One question. I'd like to know your opinion about why are we underutilizing celiac plexus blocks in pancreatic cancer? In reality, we underutilizing it. I think we should do it more often. We as surgeons should refer patients to anesthesiologists, the medical oncologists need to think about that. Why, in your opinion, in our country, we are using celiac block less than we should?
Yeah, good question. Thank you. I think they don't know how to do it. It's knowledge. And also they are scared of the complications. If you do celiac plexus block nowadays, we do with radiofrequency. Early days, we did only with alcohol. And then you had a lot of problems with diarrhea. And also you have to go through the aorta or around the aorta, okay? The two techniques. I know pain physicians who do it, and they should be interventional pain physicians, but I think it's knowledge. They are scared to do it because of the complications. Instead, they can do splanchnic nerve block, which is more safe, is next to the vertebra from T6 to T9, great splanchnic or lessened splanchnic nerve, and they can have almost the same analgesic effect as celiac plexus. Celiac plexus is more tricky, and they are scared of the complications, I think. And also, the other thing is that we need to decide of interventional therapies for pain before your patients get dodgy, meaning before your white cells go low, platelets go down, red blood cells go down, because in that case, we can't do anything. And in liver function. We have to have a good liver function as well, because if the patient is bleeding, we can't do anything.
Yes. Any questions? Yes. Thank you, Dr. Kontouli.
Thank you.